Hello again for another episode of Stories from the Edge of Life. We have a return speaker, guest, Dr. Ernst Schwarz. I'm your host, Parag Bharadwaj. I'm a palliative care physician in the US. Dr. Schwarz, could you introduce yourself to the audience again, please?
Yes, thank you, Parag, for having me on again. I'm a cardiologist, internist, transplant cardiologist, and interventional cardiologist, professor of medicine at different institutions in Southern California. And I work out at different hospitals, including academic centers in the greater Los Angeles area.
Great, thank you. So, Dr. Schwartz, I would like for you to focus on the evolution of medicine as you've seen over the years.
Well, it has changed, no doubt about that. You know, as well as I do, when we went to medical school, of course, it was a different ballgame, even though I feel it's not that long ago. My daughter is actually in the process of applying to medical school now. So, but I mean, there's a lot of things which have changed. And especially in my field, which is cardiology and heart diseases. So I remember when I went to medical school, for example, at the University of Marburg in Germany, I was in a lecture about heart attacks by a cardiologist, and I never forget that because he was wearing a golden stethoscope, and I was very impressed by that. But during the lecture, he was called out by one of his assistants that a patient actually was coming in with a heart attack. And at that time, they performed a thrombolysis, meaning gave medication, RTPA, for example, which is a declotting agent, which is given intravenously and opens up the artery by declotting the clots, basically. So that was a very impressive thing to see, because within the duration of the lecture, the patient who had significant EKG changes on the monitor suddenly had a normal EKG and was completely pain-free. So nobody would do that anymore nowadays, because in most hospitals there's a cath lab, and instead of using medications to declot an artery, we take the patient to the cath lab nowadays and do it mechanically and open the arteries up and put a balloon in and a stent, and it's done. So that has changed, but there's a lot of other things which have changed. You mentioned that before we started the discussion today. For example, in advanced heart failure, we use surgical techniques. Now we use LVADs, which stands for left ventricular assist devices, or biventricular assist devices. So machines, pumps, mechanical pumps, which we implant into the chest, into the chest of patients with advanced heart failure, either as what we call a bridge to transplant, to a heart transplant, or sometimes even as what we call destination therapy, meaning that stays in the patient as long as they live. And that's a pump, a mechanical pump, which overtakes the function of the heart. But today's pumps, they are what we call continuous flow pumps. So remember, our heart pumps, contracts, and relaxes, contracts, relaxes. So that's a pulsatile phenomenon where the contraction, blood is pushed into the body, and when the heart relaxes, the heart is filled with blood. So those pumps, the ones we use nowadays, are not pulsatile. They have a continuous flow. It's a continuous flow, like a roller kind of type of pump. So meaning that there is no systole and diastole in the classical sense. There's no blood pressure. So we talked about the vital signs. So usually if we evaluate a patient, we check the pulse and the blood pressure, because that gives us major indications about the hemodynamic status of the patient. So with those pumps, there is really no blood pressure, or hardly a blood pressure. And I even had cases where doctors called me from outside hospitals who were not aware of what a pump even is, and said, well, that patient, he has no blood pressure, he's dead, but he talks to me. True story, actually. We heard things like this. So, and we did not even know when we started those machines in the body what a constant non-pulsatile flow does to the organs, but it seems to work, obviously, and some patients, and many patients, can live with those pumps for many, many years. But they don't have the classical pulsatile flow of blood, and they don't have the classical blood pressure. So there's other ways for us to measure nowadays their vitals by measuring like mean arterial pressures. The other major change for me personally is, of course, to see that we are really shifting the paradigms of medicine from what we call reactive medicine to regenerative medicine. And that's in its early stages. But keep in mind, right now, we react to medicine. So people come to us, patients, because they have pain, they can't breathe, they have a loss of an organ function. So we react to symptoms which are the result of an organ dysfunction. Instead of just reacting to a damage which has occurred already, in the future, of course, our goal is not only to react, but to repair the damage, which we hardly are able to do at the current time, but that's where things like stem cell therapy in the future might play a major role, because with stem cell therapy, at least in theory, we want to go ahead and repair damage. And stem cells have such an enormous potential really to do that. However, as you know, at the current time, stem cell therapy is not FDA approved. But if you look at the publications in whatever condition, if you talk about heart disease, hair loss, diabetes, you name it, every single published study using stem cells has shown benefits. So there's an enormous potential, but we still have a lot of work to do in the research world and try different study protocols to evaluate the potential of those regenerative therapies. But in my opinion, that's definitely the future. And there's a reason, Bharat, you know that, why the biggest companies in the world, Google, Amazon, Apple, spend hundreds of millions of dollars right now since 5-6 years on stem cell research, anti-aging research, even what they call immortality research, which has to do with regenerative medicine and manipulation of the senescence processes of the cells, meaning the aging processes. And many people believe that within a couple of decades, we will be able to prolong life significantly, not only life, but hopefully the health span. So we don't want older people getting older and more frail, because then we need more palliative care physicians, of course. But we want older people to live longer, but living a productive life, meaning being able to do daily activities. We want to increase the health span. And that's where the focus is right now in the regenerative medicine research.
Yes, medicine definitely has come a long ways, as we were discussing. You know, we have patients who don't have measurable blood pressures. Vital signs don't really mean vital signs for some patients anymore. And then you're talking about the advancement with stem cells. And I believe you've written a book recently on the subject.
Yeah, it's called The Secret World of Stem Cell Therapy. Just came out actually in May of 2022, this last week, basically. Yeah, it's available everywhere where books are sold.
Great, great. So, Dr. Schwartz, since the theme here is stories from the edge of life, uh, do you recall any particular patient experiences that made a lasting impression on you? Because you see patients who are really very sick, who are on the brink of death. Some make it back, some don't.
Yeah, of course, there's tons of examples. I mean, if you ask me just spontaneously, there's two cases maybe I can just briefly describe, because these are cases which I never forget. So one was actually a young woman who came completely healthy, no medical history, who came to the hospital with signs of acutely decompensated heart failure. Basically, the heart was failing. And oftentimes, the reason for things like this, for conditions like this, is like a heart attack. But this particular lady, she was in her late 30s, did never have a heart attack. She didn't have risk factors for any heart disease like diabetes or high blood pressure, but she developed while we were evaluating her, actually what we call cardiogenic shock. So a shock condition because the heart was not or hardly pumping anymore. So make a long story short, this was a case of what we call a myocarditis, an inflammation of the heart muscle, in that particular case caused by a virus. This is something absolutely unpredictable that can happen to you and me at any time, today, tomorrow, you name it, whether you're healthy or diseased, whatever. And that was a completely healthy lady who acute that virus infection, which then subsequently affected her heart and led to acute heart failure. And if that's the case, those patients, they die on the spot because oftentimes they come too late to get appropriate care. And in that case, she was actually seen by another cardiologist, put her on some medication, not recognizing in that point the pending shock condition. So I was called because I was on call in the middle of the night by the intensive care team, and we put pumps in her and put her on what I called an ECMO, an extracorporeal membrane oxygenation, like an external heart-lung machine, if you wish. Like I said, a 30-something-year-old patient who was completely healthy, and subsequently she needed a left ventricular assist device and a right ventricular assist device, and then a heart transplant several weeks later, and she did extremely well. But this was someone who fortunately survived this ordeal of an acute organ failure as a result of a simple, in quotation marks, of course, simple virus infection. So not COVID at that time. Other viruses can affect the heart too, of course. And the vast majority of people who have such a fulminant virus myocarditis, like I said, they don't survive it. That lady did survive it because she was lucky enough to be in an academic center which had all the technical possibilities and expertise really to help her. But I mean, it was like 3 nights in a row we had to work on her to get her more or less stable, to be able to get those pumps in her and then subsequently getting a heart transplant. And since she was so young and this was such a stressful case, I never forget that. There was another case which didn't end that well. It was someone who actually had a heart transplant, a patient, and that particular patient was a doctor himself. And as you know, doctors and people in the medical field are not considered the best patients because oftentimes we feel we know it all and we don't. And if we do an organ transplant, of course, we require certain medications, lifelong immunosuppressives, to protect the heart. And that particular doctor thought he can handle his immunosuppressive regimen on his own. He doesn't need someone else to take care for that, which ended up in a disaster. And he developed one rejection after the other, and subsequently died of a acute on chronic rejection which was a disastrous course over several months, and couldn't even leave the hospital. And I remember that case because that death could have been avoidable with appropriate compliance of the patient. So one issue we face, or I'm facing on a daily basis right now, is really lack of compliance. Meaning, even though we have very sick patients and we have certain recommendations for therapy, for medication use, for maybe salt and water restriction in the cases of a weak heart, many patients don't follow their doctor's recommendations, oftentimes or mostly because of lack of appropriate education. They don't know why they should not drink too much water or not to have too much salt. So our job here as healthcare providers and educators is really to educate those patients and their caregivers why it is important to stay on the medication. And if they don't stay on the medications for 2-3 days, they end up in a disastrous condition and often die. And those cases are also avoidable if there would be more compliance. So we have, and it's our fault because we cannot blame patients not to follow recommendation. We have to blame ourselves, not to give the appropriate education, maybe because we don't have the time or we don't take the time to talk to the patients.
Thank you for sharing that, Dr. Schwartz. Um, on a more humanistic level, could you share your experience with these patients that are on the edge, so as to speak, between life and death? What has been your observation? Is there a theme that you've come across? Things patients say, things patients regret, things patients want to do?
I mean, yeah, the general observation is, of course, that anything which has to do with organ failure that could be potentially fatal is oftentimes a sudden major change in anyone's life. And we see that in people who are healthy and do their work on a daily basis, and within a day, basically, the whole life changes. Because suddenly they are told they have, for example, a failing heart. And suddenly they are told they have to be on medication. And suddenly they are told they can't do their work as a construction worker, for example, anymore, because they have to avoid heavy physical activity and so on. And besides having to deal with the organ problem, we as physicians sometimes forget that it is much more than that. It's a major change in the social life, in the family life. So that even financially, a chronic disease can ruin patients or individuals, because suddenly they're bombarded with hospital bills and medication bills, and oftentimes cannot even afford it. And so I think sometimes our issue is that we forget to see the entire individual patient. We focus too much on the organ system. And I've seen a lot of patients who are very depressed after hearing the diagnosis of, let's say, for example, chronic congestive heart failure, if it affects them to a way that they cannot fulfill their working activities or their social activities as they were used to do. And it affects their family life and their partnerships and everything. And depression, as we know, makes heart failure worse. And certain medications can make it worse. So there's certain antidepressive medication which might affect the heart and vice versa. So it requires like a multidisciplinary approach. And dealing with those psychological and social issues, for me personally, I always found it extremely difficult, because we are so used to run from one patient to the next, from one room to the next, from one cath lab to the next cath lab to do interventions, but we really don't take our time, and we're kind of helpless often. We can treat the heart failure, but we cannot really help much with the social issues or the family issues which come up, or the fact that patients might need other help at home. And I think that's very frustrating for me personally, because I think, well, I did a good job with the medication, for example, or with the procedure in the cath lab, but well, the patient is still suffering because of everything else which comes hand in hand with a failing organ. And that's where I get frustrated, that we can fix an organ, but it doesn't mean we really always can improve the patient's life. And that's where we have to work on, and need more expertise, need help from social work, from palliative care, doctors and others in those chronic care of chronically ill patients.
Great. Thank you. Thank you for sharing your insight. Now, you don't have an easy job. So how do you take care of yourself?
Well, I wish I would give you a good answer. I don't have a good answer. I think we as physicians, we don't take appropriate care for ourselves. I shared with you a few minutes ago that just Last night, I heard that one of my colleagues, who was in his early 50s, suddenly died over the weekend. I'm not quite sure what the reason was at this point. It was speculated possibly an acute heart attack. That was a very healthy appearing young man, athletic, very active. I think we are not doing a good job to taking care for ourselves. We should. I mean, I try personally. I try to exercise when I can, but I mean, it's always it's an issue of finding the time. And I tell my patients, you have to find the time. While I'm not really doing it appropriately either. I think honestly, healthcare providers like us should have a mandate to check their heart, for example, and their vascular system on a regular basis. Even though I haven't done it either, but we really should. Because we often forget ourselves, and then, I mean, bad things can happen at any age. As I mentioned, that young lady with a virus infection, or sudden heart attacks, or sudden cardiac death, or other issues. I had 2 other colleagues of mine dying within the last few years, completely healthy. One died of COVID, completely unexpected, another one in an accident. I'm not saying that was avoidable, of course, but oftentimes we hear about other conditions like cardiac arrhythmias or sudden death or heart attacks, which might have been avoidable if appropriate diagnostic measures would have been initiated prophylactically.
Yeah, one thing I've learned over the years is, and what you're alluding to, is that life is very fragile, and you see it one heartbeat to the next.
Right about that, yeah.
But thank you very much for sharing your insights, Dr. Schwartz. We'll hope to have you again. And thank you for all your service, and do take care of yourself.
Thank you so much, Dr. B. It's a pleasure always talking to you. We'll talk soon. Thank you.
All right, thank you.
Thanks.
Did you like this story? If so, please subscribe to this channel and like and share the video. Want more? Buy the book, Stories from the Edge of Life, available now on Amazon for more stories like this. All proceeds support Palliative Care Network, a nonprofit dedicated to alleviating suffering and improving the quality of life for patients facing end-of-life issues. Consider extending your contribution by donating through the link below. Thank you for your support.